everyone. It's a little bit awkward talking to a camera, but anyway, I'm sure you all appreciate that. I'm sorry that I can't be in Calgary, but as you know, I'm sure Jose's mentioned, I'm unable to attend. We have our own training program going on right now, and meaning right now Friday, as opposed to what really is right now, which is Wednesday. But fortunately, Mike Carlos, I understand, is supposed to be there, and Mike was a part of this, an integral part of this program, and so he'll be able to answer some of the questions that might arise regarding it. I've also sent out some handouts, as well as I've asked for a copy of the article that resulted from this initial training program to be distributed, so that maybe it will answer some questions as well. So basically what happened with this program was that Health Canada had some money available to develop training programs which were going to in part highlight the care of HIV patients in the palliative phase of their illness. And so the Manitoba Hospice Association and ourselves partnered together to develop this training program, and it was I guess Health Canada were the funding bodies, and this Canadian Palliative Care Association, as well as the NHRDP, worked together in terms of the project. So it was an interdisciplinary palliative care training program, and basically what we developed was a 2-week course with multidisciplinary teams. And the idea was that they would act as local experts and facilitators in their own regions. One of the things that we strongly believed that it was similar to what Mitchell Max had said in an article in 1988, that education wasn't enough, that it wasn't just enough to give people didactic sessions, that you do that, and you've done that in terms of pain management over a number of years, and yet behavior really wasn't modified. And so what we thought was important was that the people who we were training would actually come in and they would work with us directly. The other thing that we thought was important is palliative care as an interdisciplinary, multidisciplinary program that, in fact, we bring not just physicians, but also physicians, nurses, and social workers, and that all of them work, learn as a team and learn to work out some of their issues as teams too. We based our program on the outreach model, which Manitoba Cancer Treatment and Research Foundation, now called Cancer Care Manitoba, had developed. And what they had found was that they wanted to have care closer to home and in their own communities. And so what they hoped to do through their program was have physician extenders. And in a sense, what we were trying to produce was program extenders, so that there was palliative care of a higher level of quality throughout much of Manitoba. How they determined who would actually be a part of their program was that they looked at the number of cancer cases throughout the province. And in areas where there were at 25 new patients or more per year, those are the centers that were offered the opportunity to have outreach programs. And often the request would come from communities who had a large number of cancer patients. And what they did was they developed collaborative relationships with the Cancer Foundation, with the community hospital, as well as with the local physicians. And so then these individuals would work together and try and sponsor people to come into Manitoba Cancer Treatment Research Foundation for a period of training. So they were people, both the physicians and the nurses were actually not chosen by the cancer center, but were chosen by the local community. So they were to say, these are the people that we want to go to Winnipeg to learn how to do this particular skill. And for their training program, they had on-site training. Physicians were 2 weeks, and the nurses were there for 4 weeks, and then they would have an update every 1 to 2 years. And in their case, these outreach centers were used to monitor and deliver chemotherapy but also they learned about psychosocial issues, minimal amount at that time about palliative care, bereavement, and also some issues of transportation. So this was the model in which we were building our program. And so what we decided was that because we knew that there were a significant number of patients at each of these sites, and there was also some expertise in terms of cancer care, that we would actually target 4 different centers to pilot this particular project. And as you all know, Manitoba is quite a large province, and basically we took people from different regions. We tried to take some places where they actually had palliative care programs and others where they didn't, and from different regions of the province. So 4 different regions. There were people from Flin Flon, the Paw, Selkirk, and Brandon were the initial people who came for that particular training. We also worked in conjunction with the Manitoba Hospice Foundation, and basically the Hospice Foundation is interested in education, community volunteers, nurses, and physicians, as well as had a large part in terms of volunteer training. And so their piece of the puzzle was actually doing the volunteer training, in which they had developed a series of tapes, as well as local facilitators who would go into the same communities and train the volunteers in that region. So the objectives of our training program were to develop and pilot test an interdisciplinary program, to establish links among palliative care groups, so those who were centralized in Winnipeg and the ones out in the community, in part because we found and we knew that probably if people got to know who we were, that then we would be used more frequently in terms of telephone consultation, as well as to develop volunteer networks. I will have sent out a copy of what the course content was. I'm not sure how well this will project on the video, but basically what we did was we invited these 4 different communities, and we tried to work around, in particular, the physicians' schedule, because it was often the most difficult, because they have to get a locum and bring in a physician, a nurse, and a social worker from that community to do the program at the same time. Many of the rural communities didn't have social workers, and in that case they would send 2 nurses for the program. And so what would happen is that some of the didactic sessions, most of them would be held with all 3 of the group being present. And then there were times when all of the different disciplines would do patient rounds on our 20-bed inpatient unit, and where there'd be a large amount of teaching going on. And then at other times, the social worker would break off and go with our social worker, and the nurse would go and work with some of the nurses on the ward. And so that they were getting both the didactic as well as the practical from their own discipline's perspective. And then the other part that we had included was that they would go to the village clinic, which was the HIV clinic in the community, and again, they would work with either the physician or the nurse or the social worker in that particular community clinic to again learn about approaches in terms of care of the HIV patient. They also spent time in the radiation oncology clinic to get a deeper understanding of what radiation was all about, what was involved in planning, and what were some of the indications for that. And so it was a 2-week training program, and again, just the same kind of thing in the second week, that covered a number of subjects which you can see on the schedule that I've given you. The evaluation of the program, basically we thought it was important not just to evaluate knowledge, but also to look at some of the changes in attitudes as well as clinical practice of the people who came to the program. And what we did was a repeated measures type of thing with people who were doing the program, doing discipline-specific and non-specific questionnaires 2 weeks before they actually came and had the program, at the end of the program, and then 3 months later. And the 3 months later was intended to see if the information that they retained had been retained rather, and if the information had been put into practice. And basically, there was a chart audit which was looked at 6 months prior to their coming, and then 3 months after they were in the program, and looking at the hospital medical records institute format. Now, this is an audit that was developed by, or at least, I'm not sure it was exactly developed, but at least modified by Liz Latimer in terms of looking at palliative care practice, and it might be something for you to consider in terms of evaluation for your program. The results of the program, of the pilot project, are written up in the article that, again, I believe you're going to have a copy of. There were 4 doctors, there were 8 nurses, and there was 1 social worker, obviously reflecting the fact that there are often not social workers in the community, or if there is a social worker, there's often just 1, and therefore it's difficult for them to come in to a 2-week program. Knowledge attitudes improved between T1 and T2, and there was stability in terms of the improvement in knowledge and attitudes. So basically, that was what we were hoping for, and unfortunately, that's what we found. We also, when they looked at the chart audit, we found that there was an increased number of pain medications that were actually changed, whether it was added or one opioid was changed to another opioid, and that there was less consultation with other people around the management of the pain, so that the people who had taken the course, the physicians, seemed to be able to do it more effectively themselves. There also was, the charts reflected an increased number of DNR orders, as well as increased attention to family care issues, so different issues that were identified, that they identified in terms of problems that the families were having. So it seemed that the program had heightened people's awareness of family issues in terms of palliation. I think the real strengths of this program were that it was, first of all, interdisciplinary, and that people were taken into an environment where not just practical knowledge was given, but also where they actually had modeling of what it meant to be a team. So that, we would sit around sometimes and we'd be talking about things from our perspective, and they would be interacting and able to say, well, gee, I don't know how that would work in our, rural community, but maybe this would happen, maybe that. And so there was a real building of team at the time that the program was going on. And I thought that was really a very strong point around this kind of program. I think some of the things that helped to make this program a success in terms of the physicians and getting them to come was that there were CME credits available, as well as that there was funding for expenses and locums. And, the funding that was available came from Health Canada, and then subsequently we developed another program that came from Manitoba Health. But I think that these are things that did help this to happen, as well as, I think, a very keen interest by these physicians and nurses and the social worker. As a result of this program, we also got money from Manitoba Health. This was a joint project with Manitoba Health and our Palliative Care program, and we developed a series of instructional tapes, which basically dealt with the didactic sessions from the pilot project. And this is a list of the different ones, and again, I will have included that in the package that you get. There also were 3 other tapes that were made that had to do with the care of the patient with HIV. And in part, the reason to develop these tapes was so that we could then have the physicians and nurses who come into our centers take them back and give didactic or give sessions in their own communities, so that the tapes became a way of a focus for them in terms of education as well. And I actually have a set of these tapes, and often the residents still, although they're not up to date completely, but residents still often watch them and find them really helpful. We subsequently, after we completed the 4 centers, we developed a nursing program looking at the advanced principles of palliative care nursing. Manitoba Health funded 4 more groups to come in and to receive the training. So that all of the different major areas of Manitoba were addressed with this training program. We tailored it slightly differently for when there was just a nursing group, and one of the things that we included was something around palliative care research and wound care, prevention and management, some other things. And again, I've included that with your information. So I think that again, this was a very successful program from our perspective. We received a lot of very positive reinforcement from the participants, and the evidence that we have is not just anecdotal, but also some evidence from improvement in terms of questionnaires, both knowledge as well as attitudes, and the chart audit showed improvement. So I think that there's some really good things about this model, and I hope that it might help in terms of the formulation of how you're going to do things. So I hope you all have fun out there. I'm sorry I can't be with you, but I hope that this has been helpful. Thanks. Bye.